Welcome back to the deep dive. Today we're tackling a really important topic in obstetrics. We've got a set of revision notes here.
That's right. And we're focusing specifically on one condition, placenta accreta.
Exactly. Our plan today is pretty straightforward. Take these notes and really pull out the key high-yield stuff about placenta accreta. Perfect if you're, say, revising for an exam like the MSRA, or maybe you just want a clear picture of what this is all about.
Yeah, making the complex a bit more memorable, using these notes as our framework.
Okay then, let's dive in. Where do we start with these notes on placenta accreta?
Well, you've got to start with the basics, right? What actually is placenta accreta? According to these notes, it's essentially when the placenta attaches itself way too deeply into the uterine wall, abnormally deep.
Okay, abnormally deep. And why is that a problem?
The main issue, and the notes are clear on this, is that it makes separation really difficult after the baby's born. And why that happens, the notes point to a faulty layer, the decidua basalis. That's where it should implant and separate cleanly. But if that layer is defective, the placental villi just bypass it, latch right onto the muscle layer, the myometrium, and the big consequence: a huge risk of major bleeding after birth, postpartum hemorrhage.
Got it. So that defective separation layer, the decidua basalis, lets the placenta burrow in too far. Makes sense. Now, these notes also mention different types. How does that work?
Yeah, they do, and it's all about how deep the invasion goes. There are three main types listed.
Okay.
First, you've got placenta accreta itself. That's the most common one, gives the whole condition its name. Here, the villi attach to the myometrium. They touch the muscle, but don't really invade into it.
Right, just attached to it.
Then there's placenta Increta. This is a step deeper. The villi actually invade into the muscle itself. They're embedded.
Embedded in the muscle, okay.
And the most severe type is placenta Percreta. Here, the villi go all the way through the uterine muscle, breach the outer layer, and can even start invading nearby organs. Think bladder, bowel, that sort of thing.
Wow. Okay, so accreta to the muscle, Increta near to the muscle, and Percreta through the muscle. Understanding that progression seems absolutely vital for grasping how serious this can be. Definitely a high-yield point from these notes.
Absolutely.
So we know what it is, the different levels, but why? Why does this deep attachment happen? What do the notes say about the cause, the etiology?
Well, the notes state the core issue is those placental blood vessels just growing too deeply. That's the mechanism. But, importantly, they also say the exact underlying reason. It's not fully understood.
Right, not fully known.
But they immediately connect it to the biggest associated factor: previous C-sections or other uterine surgeries. Anything that disrupts that uterine lining, that decidua layer, seems to create a weak spot, allowing this abnormal invasion.
That link to previous surgery, especially C-sections, feels really significant. A major takeaway here.
Definitely.
And that leads us straight into risk factors then. If past surgeries are a big one, what else increases the risk according to these notes?
Yep, several key factors listed. And number one, reinforcing what we just said, is previous C-sections. The notes give some pretty striking numbers too.
Oh yeah, like what?
Okay, so baseline risk, no previous C-section, about 0.24%. With one previous C-section, it goes up a bit to 0.31%, still quite low.
Okay.
But then, look at this. With 5 previous C-sections, the risk jumps massively to 6.74%.
Whoa, nearly 7%. That's a huge increase.
It really is. Other risk factors mentioned are placenta previa. That's when the placenta is low-lying, covering the cervix. Also, advanced maternal age and multiparity, meaning having had several pregnancies before.
But those C-section stats are just
Wow.
from under 0.5% to nearly 7%. If you're revising that dose-dependent relationship, more C-sections, much higher risk, that's got to be a key point to remember.
Absolutely pivotal.
Okay, so we got the definition, causes, risks. Now, the pathophysiology. How does this deep attachment actually cause the problems, especially the bleeding? What's the mechanism described?
The notes explain revolves around that difficult separation after delivery, or sometimes impossible separation. Normally, the placenta just peels away relatively easily.
Right.
But here, because of that faulty attachment, that defective decidua basalis we mentioned, it's basically stuck to the muscle. So trying to remove it manually just tears the muscle tissue and all the blood vessels within it.
Ah, okay.
And that's why, as the notes say, it often results in, well, massive bleeding. It's the lack of that clean separation plane.
So it really comes back to that faulty decidua basalis layer. It should be the natural break point, but it's not there, or it's damaged, leading to this dangerous fusion.
Precisely.
Now, when doctors are thinking about abnormal placental attachment, what else might be on their list? What do the notes include under differential diagnosis?
It's an interesting point in the notes here. They say to consider other abnormal placentation causes like placenta increta and placenta Percreta.
Huh. So even though Increta and Percreta are technically types of Accreta,
Exactly.
the notes list them here as things to differentiate, maybe meaning you need to figure out which type it is or consider them within the broad category you're investigating. Shows how these terms get used clinically.
Yeah, it reflects that spectrum idea.
Let's talk numbers. How common is this? Is it getting more frequent? What about the epidemiology?
Yeah, this is important. The notes clearly state the incidence is increasing. It's becoming more common.
Right, and why?
They link it directly back to rising C-section rates worldwide. Ties in perfectly with the risk factors again.
Makes sense.
The prevalence figure given for the UK is around 1 in 2,500 pregnancies. They also mention it's associated with preterm delivery, and that if it's diagnosed before birth, delivery is usually planned earlier. A planned C-section around 36 to 37 weeks.
Okay, that increasing incidence linked to C-sections is a major trend. And the UK figure, 1 in 2,500, good stat for revision.
Definitely.
What about how it presents? Does someone with placenta accreta feel unwell during pregnancy?
Wait.
Are there symptoms to watch for?
This is a really crucial point the notes make. Often it's asymptomatic during pregnancy.
Silent, mostly.
Yeah, pretty much. It usually doesn't cause pain or specific symptoms while the pregnancy is progressing. However, the notes do list painless vaginal bleeding as a possibility, usually in the 3rd trimester, but they add it's actually more likely after labor starts or, right at delivery when they try to manage the 3rd stage.
Okay.
They also mention some other less specific signs, like maybe a non-reassuring fetal heart race or the uterus feeling larger than expected. But the main takeaway is often silent beforehand. The bleeding later on is often the first major sign.
That often asymptomatic part is key then. It means you can't rely on symptoms alone. Makes antenatal diagnosis in high-risk women using imaging really important.
Exactly.
So speaking of imaging, how do they diagnose it? What investigations do the notes mention?
Ultrasound is the main tool, first line, used to check the placenta's position and look for signs of abnormal invasion into the uterine wall.
Right, ultrasound first.
Then, MRI magnetic resonance imaging is listed as another key investigation. It often comes next if ultrasound is suspicious. Gives much more detail about the depth of invasion and, importantly, whether it might be involving adjacent organs like the bladder. Helps massively with planning the delivery.
So MRI for confirmation and planning.
Yeah. The notes also briefly mention other imaging techniques might be used sometimes, but really it's ultrasound and MRI that are core.
Got it. Ultrasound and MRI. Okay, this definitely sounds like a serious high-stakes situation. How is it managed, especially around delivery time? What's the approach these notes describe?
Management is really complex and needs a big team effort. The notes really stress the multidisciplinary approach. It's not just one doctor. They specifically mention obstetricians, anesthetists, vital because of the bleeding risk, and hematologists for blood product management.
A whole team effort.
Absolutely. And careful delivery planning is crucial. Lots of prep beforehand, like making sure blood products are ready, planning for transfusion. The notes mention again that ultrasound helps identify high-risk cases early to allow for all this planning.
Makes sense.
And a really critical point. Delivery must happen in a specialist center, a hospital that has immediate access to blood banks, ICU facilities, and importantly, surgeons with experience in complex pelvic surgery. Sometimes you need urogynecologists or oncologists involved if the bladder or bowel might be invaded.
Right, specialized care is non-negotiable.
Definitely. Now, regarding what happens at delivery, the notes mention a couple of main strategies. Often the standard approach is a planned Caesarean hysterectomy. So they do the C-section, deliver the baby, but then remove the uterus with the placenta still attached inside.
Remove the whole uterus.
Yes. The notes suggest doing this electively might actually lead to less overall blood loss compared to trying to detach the placenta, causing massive bleeding, and then needing an emergency hysterectomy anyway. However, there's also conservative management. This is presented as an option, may be chosen if the patient strongly desires fertility preservation. Here, they deliver the baby via C-section, but deliberately leave the placenta inside the uterus.
Leave it in.
Yeah, leave it in situ. Then they use other methods, maybe uterine artery embolization or certain drugs, to try and encourage the placenta to regress over weeks or months. But the notes are quick to add that this conservative route has its own potential complications and risks. It's not a simple alternative.
Wow, okay. That's a huge section. Specialist teams, specialist centers, careful planning, blood ready, and then this massive decision between planned hysterectomy versus trying to conserve the uterus.
Yeah.
Lots of critical points there.
Absolutely. It's complex decision-making.
So what's the outlook then? The prognosis for someone diagnosed with placenta accreta?
Well, the notes say it really depends. Depends on the severity. Accreta versus Increta versus Percreta. It also depends on whether complications develop, and critically, on the expertise of the team managing it. The good news is, with proper planning and management in the right setting, successful outcomes are possible. People can do well. But the notes emphasize there's still a significant increased risk of major complications. They specifically mention severe postpartum hemorrhage and the need for hysterectomy as things that obviously impact the overall prognosis.
So manageable with the right care, but always carry serious risks.
That sums it up well.
Let's just list those potential problems explicitly.
Yeah.
What are the key complications the notes flag up?
Okay, the main ones listed are excessive bleeding during delivery. That's the immediate #1 threat,
Right.
which leads directly to postpartum hemorrhage, PPH. That's the major concern. Then there's injury to nearby organs, bladder, bowel, especially with Percreta, where it invades through the uterus. Infection is another risk, particularly if conservative management is attempted, leaving the placenta in place. And finally, the potential need for hysterectomy is listed again, sometimes planned, sometimes an emergency complication if bleeding can't be stopped. And the notes wrap up that section saying it absolutely requires careful management and monitoring to minimize risks.
Yeah, that list really underscores the seriousness.
Mm-hmm.
Major bleeding, organ injury, potential loss of the uterus. You can see why it needs such specialized handling.
No question.
So reflecting on all this, the definition, the types, that stark link to previous C-sections driving up the rates, the complex management involving big teams and centers, the difficult choices around hysterectomy, It really makes you think about modern obstetrics, doesn't it?
It really does. And if you connect those threads, the rising incidence linked to more surgeries, the complexity of managing it, it leads to a pretty challenging question, I think. How does this global increase in previous uterine surgeries keep challenging healthcare systems? How do they cope with more and more Accreta cases? And maybe more pointedly, how do doctors and patients navigate that difficult balance between needing potentially life-saving interventions like hysterectomy and the understandable desire to preserve fertility?
That's a powerful thought. It captures that tension perfectly. The intersection of surgical history, patient wishes, and really high-stakes medical care. Definitely food for thought beyond just memorizing the facts.
Mm-hmm.
And that brings us towards the end of this deep dive into placenta accreta. Working through these revision notes, we've tried to pull out the essentials: what it is, the risks, why it's dangerous, diagnosis, management, outcomes, complications.
Yeah, breaking it down like this, point by point, focusing on the high-yield stuff, it's just a really effective way to revise complex topics, helps structure things in your head.
Absolutely. When you're facing something complex, having that structure, like we've tried to provide based on these notes, makes a huge difference in making it stick. And look, if you are revising topics like placenta accreta, maybe for the MSRA or similar exams, having good, focused resources is key. You might want to check out platforms like MSRA.com or MSRA.com. They often have this kind of high-yield material.
Good resources are invaluable for exam prep.
Definitely. Well, thank you for joining us for this deep dive today. Keep exploring, keep questioning, and keep diving deep into the knowledge.